Okay, Chapter 4 from Starkey is entitled Injury Pathology Nomenclature. Within this chapter, we're going to cover a lot of the injuries, but not in the specifics, more in the generics. So you'll be familiarized with the terms that we're going to use when we are more specific later on in upper extremity. First things first, understanding body positioning, anatomical position. I know you guys have probably heard about these before, but it's very important to understand what each of these terms are and to start using them. Proper medical terminology is very important, and at this point you should start using these terms as if they are completely natural to you. So first, anatomical position. This is your reference point of all motions. So the picture here, this person is in anatomical position. Palms are facing outward. Your shoulder is in slight external rotation. Feet in a natural position. Knees straight forward and head straight forward. That's anatomical position. Prone is just a term used for when you are lying face down on your stomach. Supine is a term used when you are lying on your back or lying on your spine. Other terminologies, we have anterior, posterior. Again, hopefully these are mostly review, but anterior means toward the front of the body. Posterior refers to the back of the body. Superior, inferior. Superior is toward the head. Inferior is toward the feet. We can also use superior and inferior as a relationship to other structures of the body. So it could be overall superior in the body, but also could be superior to something else. You can use it as a reference point. Medial, lateral. Medial is toward the midline of the body, and lateral is away from the midline or toward the outside of the body. Proximal, distal tends to be the most confusing one. Proximal is closer toward the midline of the body. Distal is further away. So that would be your wrist is distal to your elbow. Your elbow is proximal to your wrist. Again, those tend to be the hardest one. Superficial and deep refers to the depth within the body. So your skin is superficial where compared to your muscle, which is deeper. So it's more of the depth in the tissue versus different body parts. And then cranial and caudal are terms that you may hear of, not used all the time. We tend to use more superior and inferior, but when you specifically say cranial, you're referring toward the head, and when you say caudal, you're referring toward the rear end or the lower leg. Movements, again, hopefully you guys, after having your goniometry class, understand most of the movements, but specifically here in the upper extremity, flexion and extension is demonstrated in this picture here. Bringing your arm to the front of the body is flexion, and bringing it away from your body is extension. AB adduction over here, coming away from your body is abduction. Coming back toward your body is AD or adduction. Then we have horizontal abduction and adduction. We take his arm here, we start in a neutral position. When we bring it, we'll start down here. When we bring it out, that's horizontal abduction. And when you bring it back in or even continue over here, that's horizontal adduction. Same kind of thing apply. I always thought of it for the adductions. When you add, you're adding it back to the body. So when you bring your arm back down, when you bring your arm over, those are both adduction, adding more to your body. I've left shoulder internal rotation a little bit separate here because there are different ways you can look at it overall. Internal and external rotation of the shoulder is not a hard concept, but you have to make sure that you understand what you're looking for. So all three of these pictures down here are demonstrating internal and external rotation of the shoulder. We tend to see the person like this, whether they're standing or lying supine on a table, where we have neutral position straight out in front. External rotation is this way, and internal rotation is this way. But we can also have the person have their humerus up against the side of their body with their arms starting straight out here. When they move it out here, we're moving into external rotation, and move it in toward the body, that is internal rotation. Again, same kind of thing over here. The humerus, instead of being straight out alongside the body on the frontal plane. It's sticking out into the sagittal plane. And now we're just doing internal rotation from here and external rotation from there. So what I tend to recommend is finding one that works, which tends to be this one, and memorizing what it looks like so that you can have a reference point. So in case you see someone who looks like this or who's doing it like this, you can take what they're doing, bring it back to this position, and have a reference for it. Supination, pronation. Hopefully you guys have seen this one before. Here's the picture. You can start straight up and down with your thumb when your palm is up. And this is just a forearm motion. So in the upper extremity, the forearm has to be working. So in this case, the person's elbow is bent. We're only looking at the forearm here. So when we move over, palms up, supination, like you're holding a cup of soup. And if we go the other way, where your palm is down, that's pronation. Radial and ulnar deviation. When you look at this, remember to go back for both of these to anatomical position. Make sure you refer to anatomical position because that will make a difference. But radial deviation is going to be movement of the wrist towards the thumb side, which is the radial side. The ulnar deviation is moving toward the pinky side, which is the ulnar side. So if you're moving toward your thumb, that's radial deviation because the radius is over there. If you move it toward your pinky, that's ulnar deviation because the ulna is over there. And then the last three here, protraction, retraction, elevation, depression, and upward, downward rotation. Those are all scapular movements. So if you can see the picture down here, elevation is pretty obvious. You elevate both scapula. Depression is the opposite of that, where you actually pull both scapula straight up and down. These next two crisscross like this. It's called adduction here, but it's also called retraction. I prefer to use the terms retraction and protraction. Retraction is pulling the medial parts of your scapula together, like pinching or squeezing your shoulder blades. And protraction is when you actually go further apart, like you would if you were rounding your shoulders. And the last two are upward and downward rotation, where we're looking at the points or the bottom of the scapula to see where they go. So this guy is basically just standing in neutral position, and you could call that downward rotation. But when you lift your arms, the scapula is attached to the humerus, so your scapula has to actually rotate upward in order to have full arm motion. Planes of the body. For whatever reason, a lot of students have trouble with planes of the body. There are three primary planes, and there are going to be specific motions that occur within each plane of the body. So first you have to understand which plane is in which direction. So the sagittal plane is the plane that is going to cut the body into left and right portions. Sagittal planes technically can occur anywhere. It does not have to be specifically in the middle, but there is a plane called mid-sagittal that specifically cuts the body into right and left halves. The next one is coronal or frontal plane. I tend to say frontal plane, but do know both of these terms are the same plane. The coronal or frontal plane will cut the body into anterior and posterior sections. So this is the coronal plane line right here. And then the transverse plane is going to cut the body into superior and inferior portions. So it's going to be really important to understand what motions occur in which plane. The way that I always remember this, and the way that I always teach this, is to think of these actually as pieces of glass. And whatever motion that you're trying to do, if it breaks the glass, it does not occur in that plane. So if you think about it, let's start with just shoulder flexion extension. So if we did shoulder flexion and extension, his arm's coming up this way and then back this way. So we are going to end up breaking the transverse plane. So flexion and extension does not occur in the transverse plane. We're also going to end up breaking the coronal plane or the frontal plane because it's right in our way of flexion and extension. So flexion and extension does not occur in the frontal plane. The sagittal plane is right here. Flexion and extension can occur without breaking the glass of the sagittal plane, so therefore flexion and extension occurs in the sagittal plane. I will leave it up to you guys to determine which of the motions occur in which plane. I believe that's a question on one of your worksheets. The next portion here is kind of more terminology, and this stuff, these muscle contraction ideas, are a very big principle that you must understand. So understanding how the muscles contract in multiple ways, and then being able to identify during different activities how are the muscles contracting. So first, just definition-wise, there are concentric muscle contractions, and hopefully you know this by now, that the concentric contraction is the shortening of the muscle. So in this picture, this guy over here with his big muscles, he is doing a bicep curl. He is coming up with it, and the bicep brachii is actually shortening, which is why it is large. Because he's actually working and actually shortening. If it were lengthening, it would not be sticking out so much because it would be lengthening and you would lose some of that mass in the middle. So concentric is pretty straightforward, understanding that it is the shortening phase. Usually when it comes to activities, it's more of the explosive phase. If you think about jumping on the way up, the explosive part, it's a lot of your body is contracting concentrically. But whenever you're landing, that's when it becomes the eccentric part. So the eccentric contraction is the lengthening of a muscle. So it's still the same muscle group, it's just lengthening. So if you want to go back to this muscle guy, on the way up, when he has his doing his bicep curl, on the way up is a concentric contraction. But if the barbell was up here and he is lowering it down slowly, that's an eccentric contraction. So most activities that we do, a muscle, one specific muscle or muscle group, will do both concentric and eccentric in order to perform the entire activity. So if you are jumping, the jump up, the explosive movement, is concentric, but when you land, all your muscles are now lengthening to absorb the force. That all is now eccentric. Also over here in this picture, if she was doing a push-up, the up part, the explosive part, is going to be concentric. When, let's say it's for her triceps, on the way up, she's exploding and she's actually shortening the distance here, concentric contraction. But as she lowers herself back down and maintains this position, then that is eccentric because the triceps are actually lengthening. And then the third type of contraction is going to be an isometric contraction. And actually, if we go back here, this is an example, since we freeze framed it here. Say that this is a plank, or she's just holding this position and there's actually no movement going on. That's an example of isometric contractions. The definition is tension produced by the muscle but does not have any kind of muscle joint movement or muscle change in length. So it's holding the position. You're producing force, but you are not going up or down. You are not moving. You're just maintaining it, but you are producing force. And if you guys remember the President's Fitness Test, but your arm hang is an example of an isometric contraction where you grab the bar, you keep your elbows bent, and you have to hang there. If you start to slip down, then you start to move, and it becomes concentric or eccentric. But in this case, she is just hanging there, so it is just a concentric contraction. I'm sorry, isometric contraction. And then here's just another example of all three. Here's your barbell. So as they bring the barbell up, then that's concentric. Lowering it back down, that's eccentric. And then if she's going to stand there and hold it out to the side and not move it around, that's your static, or also called isometric contraction. Okay, so the next thing here then, again, more background information, is the tissue's response to stress. There's this theory called the physical stress theory, and it is defined as tissues react to the forces placed on them in a predictable manner. We understand how our body is going to react. In general, it's a really important concept to understand that your body does not like to be stressed. And we hear the term stress a lot. Stress can be physical factors, physical stress to the body, but it could also be social, emotional, psychological, all that stuff. When you say, oh my gosh, I'm so stressed out, that is not what we're talking about. That is stress, yes, but in terms of this theory, we want to talk more about the actual physical stress applied to the body, because that's where we want to talk about the actual tissues. So if you understand that your body does not like to be stressed in general, but specifically doesn't like to have any kind of physical stress, then we can predict what's going to happen. Your body wants to maintain homeostasis. So if your activity level drops below homeostasis, if you stop doing something you used to do, your body's going to respond to that. If you don't use it, you're going to lose it. So what we see is if you don't use it, you are going to have atrophy. So if your activity level or physical stress has dropped below your normal levels, then your body no longer wants to maintain whatever you had before, so it starts to waste away. Why you have to continually have to work out in order to maintain your muscle mass. If not, you're going to get rid of it because your body does not need it any longer. Why should it feed and keep muscle there when it uses up way too many calories when you don't actually need it? So that's where we see atrophy, or the wasting away of muscle. Hypertrophy is the opposite. So if you're at homeostasis in your normal daily life and then you add activity or stress, physical stress, to your routine, then at first your body does not like it because you are actually putting too much stress on your body. So the way your body adapts to that is making it bigger and stronger, or better endurance, or whatever activity you're doing, because your body does not want to be stressed. It makes adaptations, and now that activity becomes easier. So for one example, if it's just your muscles, you don't do anything for a long time. That's your normal homeostasis. Then you add in a workout program, which is really hard early on. But then relatively soon, you're able to either keep moving up, or whatever activity you're doing becomes very easy. That's because your body has adapted to the stress. So in order to keep seeing results, you have to keep stressing your body, which really just means keep adding more weight if you want to see any kind of changes. So here is basically just a chart to demonstrate what I just said. You have your normal stress in your daily life. Again, this is physical stress. So maybe you're just a regular college student and you drive your car to work and to school, you carry your backpack, you walk across campus, you might walk up some stairs, but overall you don't really do all that much. That is your homeostasis. That is what you do. Now let's say you break your leg and you can't really walk anymore. So during these next 6 weeks, you're going to have to be rolling around in a wheelchair. So your normal level of maintenance of stress has just dropped. There's a good chance you are going to see some atrophy, especially in your leg muscles, because you're not using them. That's because your normal daily stress has dropped and you're now losing mass. That's not very desirable. We really don't want to see that. The other thing can also happen, you're that normal college student, but now you start to ride your bike to school, you start to lift between classes, you start to actually increase the amount of physical stress in your life, and your body does not like it at first, but then after a while we start to see hypertrophy. We start to see changes in your body as a result of that stress to help minimize the stress to your body. That is desirable. We want to see that if that's your goal. This is where activities become easier and you're able to lift more, run further, run faster, whatever it is. That can go bad quickly if you don't control the amount of stress. This is where you have to make sure when you start a new exercise program, you do not do too much too quickly. You have to very much make sure you ease yourself into it, because if you went from your normal homeostasis to, let's say, insanity program, where you are jumping every day or 6 days a week with little to no rest, you went from never jumping ever for the last couple of years to jumping for an hour 6 days a week. That is a huge jump, and the chances of you getting injured are going to be very, very high. This is very common. Not that I'm bashing programs like P90X or Insanity. They get great results, but it depends on where you start from. If you're a regular person who has not done that level of physical activity forever, and you start that, you're going to end up in this column. You're going to bypass hypertrophy, and you're going to go straight to injury because your body cannot handle that quick of a stress. You have to build up to that stress level. The next concept here is a stress-strain relationship. This is talking about how much of a tensile force is a pulling force, how much of a tensile load or a tensile force can a tissue handle before it becomes damaged. Tensile forces are, again, your pulling forces. Muscles are there to be resistant to tensile forces, and so are ligaments and capsule. So the primary structures we talk about when it comes to ligaments, capsules, and muscles are all designed to withstand tensile force. That's also the same method. Too much tensile force is what's going to end up injuring those same structures. So how much force can these tissues actually take before they rupture? There's a graph on the next slide to explain this. Just also kind of a side note here, the amount of tissue stiffness is going to increase with age, and the stiffer the tissue is, the less tensile strength it can handle, and the more likely you are to get injured. So when it comes to the stress strain curve, or also called the load deformation curve, I tend to use the term load deformation curve, but it's the same thing as the stress strain curve. This is what the load deformation curve looks like. There are 4 specific points along this curve. And again, this is a tissue's response to a tensile force applied to it. So when you're at rest with no force applied, the tissue is relaxed, and it actually has, it's not completely taut. It is relaxed, and there's actually some crimps or some ripples or waves within the tissue because it's not all the way taut. As soon as we start applying a tensile force, those crimps are going to end up straightening out. So that's called the toe region. The toe region is when there is no force applied over here, and there are some, kind of crinkles or waves within the tissue. Then we start applying some force, a very low level of force, and in this initial region, basically, instead of having those ripples in it or crimps in it, it's that the tissue, whatever it is, a ligament, muscle, starts to straighten out. Within the toe region, there is very little force applied, just enough to straighten the tissue out. No changes are going to occur. If we continue to add more tensile force, then we enter into the elastic region. The elastic region is when more force is applied, but because tissues are made up of collagen and elastin is the elastic part of the tissues, we're able to actually stretch out these tissues, but because we're in the elastic region, they actually go back together. Not together, but they go back to their resting length. There is no permanent change in tissue length in the elastic region. Yes, the tensile force does increase the length while the force is being applied, but when the force is released, the tissue goes back to its regular resting length. That's a really important distinction, because in the plastic region, more force is applied. The tissue does lengthen, but it has lengthened beyond elastin's ability to let it go back to its normal shape. So once you reach the plastic region, we actually see permanent or residual changes. The changes in the length of the tissue that we saw, the tissue does not go back to its resting shape. So it stays longer. Not that it's damaged, it's just stretched out. Where here we stretched it out and it went back together. In the plastic region, you stretch it out and it stayed stretched out. And then once we hit the ultimate failure point, that is when the tissue will actually rupture. So this is the very end where too much force has been applied and now the tissue has ruptured because it's gone beyond what it could handle. The next thing here is your mechanism of injury. We've talked about this a little bit in the last chapter. It is a vital part of the history. It's what the patient is going to describe to you. How did this happen? We're looking to narrow down between acute and chronic type of injuries, and more specifically, was it macro-traumatic or micro-traumatic? So just kind of some terminology here. Macro trauma is trauma that is caused from one single force, and that force exceeded the tissue's failure point. So one force that was large enough to cause the tissue to actually be damaged. Where microtrauma, on the other hand, is not one large force, but it's repeated submaximal forces over a period of time. And the big part here is not only repeated forces, but repeated forces when your body was not able to adapt. Like we said in the physical stress theory, your body does not like to be stressed. When it is stressed, it actually breaks down. we need to have our body, we need to allow our body time to build back up. So when you are doing physical activity, why things like insanity are not a good idea for someone who is not physically active is because you're constantly breaking down tissue and you're not giving your body time to heal. So overuse injuries and stress fractures are primarily caused because tissue breakdown outpaces tissue remodeling, and that's because of those repeated submaximal forces over time that did not allow your body a chance to heal. Alright, so the next section here is getting into the more specific types of injuries. The first one is just musculotendinous injuries, and these are a very broad category. Musculotendinous, we have a musculotendinous unit, and that encompasses the whole muscle. The muscle, the tendon, where the tendon meets the bone, and where the muscle meets the tendon. So all of it. All the parts of the muscle. So a musculotendinous injury encompasses injury to the tendon, to the bone tendon, to the musculotendinous junction, and to the muscle belly itself. There can be partial tears, there can be full tears, there can be, a wide variety of things that happen. Tendon tears are more difficult to do. The tendon is very, very dense connective tissue. There obviously can be tendon injuries, but a lot of times we see the tendon oftentimes avulse from the bone because the tendon itself is so strong. The muscle belly is usually at a little bit higher risk for injury. And if you do actually injure the tendon or the muscle itself, you're going to have a problem producing force. If the muscle is actually injured, then its ability to generate force is going to also decline. It could be declined primarily because of pain. So if we have a decline in force production, it could be because it just hurts too much to do it. It also could be that the tear is bad enough that the fibers that are going to help produce force are no longer there. They've been torn. So injury to a muscle is called a strain. A strain is a non-contact injury to the musculotendinous unit. Generally speaking, strains are caused by tensile forces. So just like with the load deformation curve or the stress strain curve, tensile forces or pulling forces are the primary cause of injury. Whether it's overstretching or whatever it is, the muscle has been pulled too hard from both ends. So lots of different types of mechanisms for that. Another common way or thing that we see is muscle strain is a result of dynamic overload. And if you think about it, we see a lot of hamstring strains. Even in very high level athletes, professional baseball players running to first base pull their hamstrings all the time. Sprinters pull their hamstrings, runners. These people know and understand and are very highly trained, very physically active individuals. They have the flexibility, they have the strength. What are these people doing or not doing that is causing them to get these strains? Well, really, they found that stretching has little to no impact on muscle strains. What we actually see here is something that we can't really control all that much, and it's through dynamic overload. So think about a baseball player sprinting down the first base line to first base. The quads and hamstrings are taking turns contracting. When you kick your leg out, your quad is contracting. When you make contact and pull your leg through, hamstring. So you're constantly switching from quad, hamstring, quad, hamstring. In the regular person, the quadricep muscles are much stronger than the hamstring muscles. So when we have dynamic overload, what we actually have going on is as the quads are kicking your legs out and they're concentrically contracting, we also have the hamstrings eccentrically contracting. So basically there's a tug of war between the quads and the hamstrings, and the stronger muscle in that case is going to win, and in that case it's going to be the quad. So this is really a lot of times we see these hamstring strains are a result of mistiming or misfiring of the quads and the hamstrings. And then when we start to grade these strains, first degree or grade 1. They're used interchangeably. First, second, third degree, grade 1, grade 2, grade 3, same thing. When it comes to a strain, a first degree strain is damage to less than 5% of the musculotendinous unit. So there's stretching, but there's very minimal actual damage. There is some pain. You are not really going to find any palpable defects. You might see a tiny bit of ecchymosis, but probably not. Pain is going to be your primary factor here. I'm going to skip second degree and go straight to third degree. Third degree is complete and total rupture of the muscles, the blood vessels, all of it. It's all gone. There's an obvious defect because the muscle tendon is no longer there. Tissue becomes ischemic, no more blood flow to the area, and there's tons of pain, swelling, ecchymosis, all of it. So a first degree is less than 5% muscle damage. Third degree is 100% damage. It's all gone. So that means second degree is somewhere in the middle, somewhere in that middle 95%. Obviously, that's a very, very large range. Not that it's wrong to diagnose a grade 2. Just be aware that grade 2 is more than grade 1 and less than grade 3. So there's going to be damage, there's going to be pain, there's probably more ecchymosis. You may or may not start to feel a palpable defect. Like this is more pronounced inflammatory response. But it's such a broad category. Be careful when you start talking about return to play. So, you know, a grade 1 strain, you might be out a week or two. A grade 3, you're going to be out for a couple of months. A grade 2 can fall anywhere in between. So depending on how much damage you actually have, if you're closer to maybe 15% damage, then yeah, you might only be out a couple of weeks. If you're closer to 80% damage, then you're going to be looking at a lot longer time for rehab. So really just be aware of where that grade 2s or second degree strains have a very broad category and are not going to be near as cut and dry as first or third degree.